On today's episode of reallifepharmacology.com, I'm going to be covering acetaminophen. Acetaminophen goes by the brand name of Tylenol. It is one of the most common analgesics, one of the most common antipyretic or fever-reducing medications that you'll see out there, used from pediatrics on to geriatrics for the management of pain and fever primarily. Now, the mechanism of action of acetaminophen is a little bit of a mystery, so to speak. They've got some theories, some suspected mechanism of action. It may be kind of a moderate inhibitor of prostaglandin synthesis. It might kind of also act, centrally in some way, shape, and form to block pain impulses. Bottom line, I don't ever recall being asked the specific mechanism of action on an exam or anything like that because it's not really well understood. So I would say focus more so on acetaminophen being a fever-reducing agent that can certainly act on that, as well as relieve pain. Now, when I compare acetaminophen, I always compare it to NSAIDs. So classic example being ibuprofen. Both are available over the counter. Patients have easy access to them. And I think you definitely want to know the differences between acetaminophen and NSAIDs. So one of the main differences, I would say, is acetaminophen tends to be a little bit easier on geriatric patients. So the NSAIDs can, cause kidney trouble, cause trouble with heart failure, can cause trouble with GI bleeding. And acetaminophen doesn't really do that, certainly not to the extent at all that NSAIDs do that. So generally, it's a little bit safer in most situations. Again, you have to look at the patient scenario, what's going on with them. Probably the biggest thing that I look at, that I review, is I look and see if they have any liver issues, liver concerns. Do they have cirrhosis of the liver, active liver disease in any way, shape, or form, where acetaminophen might be a little bit more of a risk to that type of patient. Other considerations I'll look at is other medications that a patient may be on. So if we've got a patient on isoniazid, for example, that's kind of a classic liver toxic agent, okay, that maybe could potentially enhance the risk of liver issues there. Amiodarone, another example there. Maybe a methotrexate can cause some liver issues. So, you might have a patient on numerous medications. Oftentimes those are the people that I work with. And if you see a bunch of liver toxic agents, you're probably going to want to be a little more hyper aware of using that as acetaminophen. Not that necessarily you can't, but if you do, you want to keep an eye on that liver function for sure and make sure that the patient is okay there. One other medical concern I have in patients that we're going to recommend use acetaminophen for, let's say chronic pain management, osteoarthritis, is patients who have had trouble with alcohol. So alcoholic patients, they may already have pre-existing liver issues, and doing a significant amount of acetaminophen could potentially exacerbate that. Other patients that I'm going to look out for are patients who routinely take a lot of over-the-counter agents. I'm going to really target them and make sure they're well educated about the over-the-counter medications that they're taking so that those meds don't have acetaminophen in it. In addition, we've got plenty of prescription medications as well. You think of the combination opioids with acetaminophen. There's Percocet, oxycodone, and acetaminophen. There's Norco, which is hydrocodone and acetaminophen. Just making sure that that patient is educated and aware that we're not going over that 4,000 milligram dose threshold. That dose threshold is generally set at 4,000 milligrams per day as the max. With that said, I have seen individual cases where lower amounts have been recommended. So maybe we've got a patient with some borderline liver issues. Maybe it's a very, very geriatric patient that we've got some concerns in about going over that limit. You may see target limits set at lower amounts than 4,000 milligrams there. Dosing in pediatrics, 10 to 15 milligrams per kilogram per dose is the usual point we go to there. It's not a bad one to commit to memory. It's definitely so frequently utilized to help with fever and pain in our pediatric patient population. Mentioned the combination products, prescription combination products, the Vicodins, the Percocets, the Lortabs, things like that. Keep an eye out on those, as well as the over-the-counter preparations, the Tylenol PMs, the cough and cold preparations. So many of these combinations contain acetaminophen, and you definitely want to educate your patients about those combinations, and to really look at the back of labels to get an assessment there. An important test question that I always see come up, the antidote to acetaminophen. So in the situation of unintentional or intentional overdose, the antidote is acetylcysteine. So definitely a good one to remember that can come up on your exams for sure. Acetaminophen in general, I'd say, is pretty well tolerated as far as side effects goes. Every once in a while I'll see some stomach upset. Maybe in a rare situation you might see a rash or something along those lines. Again, probably by the time you see a patient, you work with a patient, at some point they've had acetaminophen in their life and they know, whether they tolerate it or don't tolerate it. But very, very seldom do I see patients that are intolerant or allergic to acetaminophen. It really doesn't happen too much. It's overall a pretty well tolerated medication. Please take a quick time out, go support our sponsor, and we'll wrap up acetaminophen when we get back. Whether you're a nurse practitioner, nurse, pharmacist, pharmacy student, med student, meded101.com has a growing list of great resources to help with board exam preparation, as well as becoming better at medication management and pharmacology. meded101.com/store is a fantastic resource you need to check out. Again, meded101.com/store, STORE. There was one other comparison that I wanted to make, acetaminophen to NSAIDs, and NSAIDs can definitely be a lot more advantageous in the setting of inflammation. Acetaminophen doesn't do that great a job. It helps with pain, it can help with headache, and fever, of course, but acetaminophen itself does not do a great job of reducing inflammation. So disease states that I think of, the classic example is rheumatoid arthritis. It's a disease of really significant inflammation, and acetaminophen just might not be that effective at helping with the pain and inflammation associated with that. So kind of one more differentiating factor between acetaminophen and the NSAIDs there. Drug interactions, acetaminophen is usually pretty well tolerated, pretty minimal on the common drug interaction side of things. I did kind of point out before, if you've got drugs that are high risk for liver toxicity, that may be a little bit of an additive drug interaction that we might need to kind of watch out for and monitor that liver function. One other one that I've maybe seen rarely is with warfarin. It's definitely not, in my opinion, definitely not as bad as the NSAIDs in that drug interaction. But maybe when you go from really low doses to really high doses of acetaminophen, there might be a low potential that you see some alterations in that target INR and raised concentrations of warfarin within the body. So again, kind of summing up drug interactions, there aren't a real a high number of common drug interactions that happen with acetaminophen. And again, it's kind of another reason why it's the preferred agent in maybe our geriatric polypharmacy type patients. I hope you enjoyed the episode today on acetaminophen. Check us out, reallifepharmacology.com. I've got that free giveaway. It's a 100-question practice pharmacology exam, absolutely free to you for kind of subscribing and following the website and the podcast, of course. Take care and have a great day.